thank you for being with us at our right here University Best Practices Sacramento region meeting today. It's a blustery day out. I appreciate all the efforts that you made traveling to get here. I know that many of our guests who have RSVP'd haven't quite rolled in yet, but we have a very exciting program today that Dr. Arevalo, our co-chair, will introduce in a moment. And I just would ask you all to hold your questions for Dr. Shatzel until he gets through his slides. So with that, Dr. Arevalo, would you please introduce our esteemed speaker, Dr.Alan Shatzel. And thank you, Dr. Shatzel, for being with us.
Well, thank you, Hattie, and again, thank you all for coming on this wonderful Monday. We finally have gotten some rain, and we hope we get some more, but this is a continuation of all of the good work that we're trying to do to reach out to the community to prevent the complications of stroke and cardiovascular disease. And so you being here is critically important. And again, this really is about a partnership, about a collaboration with all of us in this room and those who want to be in this room but can't be in this room. And of course, at the end of the day, it's about our patients trying to figure out how do we address this very serious set of complications and problems within our community. So with that, it was a continuation of our discussion around stroke and stroke prevention and stroke therapy, and we're very delighted today to have Dr. Alan Shatzel, who is going to be talking to us about the 21st century stroke care, robust responsiveness and reliability impact of organized systems for comprehensive care and collaboration. Dr. Shatzel has done a lot of great work, and he's currently the staff neurologist for Mercy and heads the stroke team at Mercy. And he has an amazing CV, and I will ask you to please turn to the CV to read it yourself. But we're really delighted and very excited to have Dr. Shatzel present this, and then we're going to have some time for interaction so that we can ask questions, and then we'll get your thoughts from the audience. Dr. Shatzel.
Thank you for having me here today. It's a great honor to speak before the Sacramento University Best Practices and Right Care Initiative. Let me switch out the slides here real quick. So my title sounds really fancy, and it sounds like I'm going to spend all this time talking about robots, but I'm not really going to spend a lot of time talking about robots. I'm going to talk about organized systems of care. How do we make certain that people get the best care possible, access to all the resources that are sometimes clustered in big, large cities and large tertiary level centers, and not out where people may need access to those resources. There's a lot of things that have influenced my thinking over the years, and here's some examples of where I've gained information from: the American Academy of Neurology, Royal Society of Medicine meeting in London, where they talked about e-health, telemedicine, and aging. It really tweaked my thinking quite a bit about how we organize our systems of care. The emergency neurological life support certification to the Neurocritical Care Society. Quality through collaboration, addressing the future of rural health, which is a great book if people haven't had access to that. And then, of course, crossing the quality chasm, which talks a great deal about access, service, quality, and how do we improve systems of care. I think we're getting to a point where we can start realizing, more than 10 years ago, it was written in Crossing the Quality Chasm. We're getting to a point where we can realize this dream and achieve 6 aims. Of course, the American Telemedicine Association. Quick story also that has influenced my thinking and what I do. I'm a neurologist. I help direct the Neurological Institute for Dignity Health. I help direct the telemedicine network for Dignity Health. And I'm very passionate about what I do and making sure people get the right care at the right time. When I was a young boy, I witnessed my grandfather have an acute neurological event. He had acute stroke symptoms, weak on one of his sides. I didn't know what a TIA was then, I didn't know what stroke was, but I knew something had happened to my grandfather. Fortunately, he resolved very quickly, and I didn't really know what to do. I didn't have any idea what to do in that scenario. So in the next day or two, I told my grandmother, who made sure he got into his physician, his care, and he ended up having carotid disease and got a surgical carotid endarterectomy. Fortunately, didn't go on to have a completed large stroke. That's a big part of why I'm so passionate about stroke care. One other quick story. My daughter turned 10 years old yesterday, and we had friends come from the Bay Area. We had neighbors from across the street, and you know, we were having a great time. We had a brunch, and we were hanging out. My neighbor, who's my age, really doesn't have any medical issues at all. He suddenly had trouble speaking. He was weak on his face, weak on his right arm and leg. And it's not every day that, you know, I witness a stroke. I take care of hyperacute stroke all the time. So, but we called 911. We did everything right. We documented the onset time, and he got over to the hospital. His symptoms had resolved. He's got a little bit of numbness in his fingertips still, you know, and it made me think a lot about how do we get our community educated about what to do if someone has a stroke? Because too often I see people who don't come in right away, who try to ignore their symptoms or think they're going to get better on their own. And you know, not everyone is sitting in the living room of a neurologist. Right? So a big part of my discussion, I have a lot of slides to go through, is going to be talking about how do we get the community educated, how do we make certain they understand how to act and react when acute stroke symptoms happen, how do we make sure they know their numbers and get prevented from having stroke. If they land in the emergency room with stroke, the system has failed in some way. They haven't been taking their blood pressure medicines, or they haven't been on their cholesterol medicines, or they didn't take their anticoagulant, or their INR was not in the appropriate range. However, there are people just like my neighbor who do not have any risk factors known. He may end up having other conditions now. He might have hypercholesterolemia, but it was not known. And how do we make sure that people get in and get cared for right away? So with that, we'll start out with a few questions to establish a baseline here. And this audience response system, see if I can do this. So the first question is, the only FDA-approved medication is safe and effective for carefully selected stroke patients. This was during a 5-year NIH, NINDS, National Institute of Neurology, Neurological Disorders and Stroke clinical trial. It was approved when? Choices are 1996, 2004, 2008, and there are no FDA-approved medications. I guess if you have a text.
Yep. So you pull out your cell phone and you text the keyword of your answer to 22333.
So tell us again.
Text to
start a text message.
Yep. To 22333.
22333.
Okay, and then you text your any one of those keywords. A UBP, B UBP, depending on which one you want to answer.
So
Did everybody get that? That you just so if you.
We're going to get a few responses.
Okay.
We got 7 respondents.
Mine is not accepting a 5-digit. It wouldn't let me send 3 5 digits. So I shouldn't have an opinion anyway.
So the answer is 1996. That's when the medication that's available for acute ischemic stroke and select patients within a very tight time window of 3 hours was approved for the use. So let's try the next question here. ones that take usually.
Not this one.
Click again.
Click previous.
So Chad, do you want to talk people through it? Is it like each time it's essentially the letter A, B, C, or D,
Right.
and then U, B, P after that?
Yeah, there's a different keyword for each answer. So now that you've texted once to that number, you don't need to enter it again. It should go right through.
Okay. Technical errors.
Now
I have them built into my slides.
it doesn't want to work at all.
What's the key word that we're supposed to enter?
What's the number?
It says we have to enter a keyword in order for a letter to be recognized.
The answer is What's the number? What?
I can't believe
22333.
we're having a little bit of technical difficulties, everybody. We're trying a new audience response system, and Tim, there's a seat right up here if you would join us.
I can't do this. It's not working. It's not working.
So I have the
Sorry, we saved you a spot.
And then we just put
So the audience response system is not working, so I have the questions built into my slides already. So the answer to the first one was A, 1996. So nearly 20 years, if you include the clinical trial, more than 20 years experience with this medication, and yet people are not gaining access to it. Question number 2, currently the gold standard medical treatment for acute ischemic stroke patients with symptoms less than 3 hours is provided for what percentage of eligible patients? So A is 90%. Any takers on 90%? No. B is 50 to 60%. People get access to the medication that's approved by the FDA standard. C is 25 to 30%. Couple, few, 3 hands. And D is less than 10%. And unfortunately, the people who voted for D are correct. Somewhere between 4 and 8% of people who are eligible for the medication are receiving it. Here's a thought-provoking question. If a family member or friend presented to an emergency room with acute neurological symptoms, one would expect a neurologist to evaluate, diagnose, discuss available treatments, and to improve the outcome. So A is yes. We should reasonably expect that someone with acute neurological symptoms would get evaluated by a neurologist.
You expect it, but you don't care.
And then B is no, we shouldn't expect that. Couple people. So I think that all people deserve an evaluation if they have acute neurological symptoms to determine how best to approach their care.
So would you ask the question deserve versus expect?
What's that?
Would you ask the question deserve versus expect?
You could change the words deserve.
Deserve. This is kind of an audience who's talked about this, and so they know that, the difference between deserve and because I think all of us in this room would agree that we expect that our expectations are informed by our experience. Yeah.
So what percentage of the time do patients actually get an assessment by a neurologist? Are you saying it's
Depends on where they go. It depends on where they go. If they go to one of the hospitals in Sacramento, it's nearly 100%. If they go outside of Sacramento, a rural access hospital, a place where they don't have neurologists on staff, they may not have access. So as the talk goes, we'll build on this idea. Good, crossing the quality chasm. Quality problems that I like this quote, and that's why I'm just going to read it for you. The quality problems occur typically not because of failure of goodwill, knowledge, or effort or resources devoted to healthcare, but because there's a fundamental shortcoming in the ways care are organized. Okay, and the American healthcare delivery system, we needed a fundamental change, and this is more than 10 years ago whether these thoughts were coming out. The current care systems cannot do the job. Trying harder doesn't necessarily work. We have to change the systems of care. And I thought about a picture like this because times have definitely changed from the phone booths and lines to get to the phone booth. Nearly everyone has their phones now, and it's a distributed kind of network where anyone can make calls in real time. Unfortunately, our healthcare system is built on a time when there was only these phone booths and just phones on the wall. There before technology that has evolved over the last decade or more was freely available. But yet we're still having trouble trying to leverage technology effectively to make sure that people get good access to care. The other challenge in our health system is it's siloed. We have, not only financial silos, but clinical silos, and just not enough access to care and good quality service across all of our hospital centers. And we need to break down these silos and get everyone collaborating and working together to make sure people have access to the best knowledge and the best outcome possible. There's a lot we can learn from maps. This is the population distribution in the United States, kind of a topographical map. And what happens is physicians follow the population. So you have a much higher density of physicians per capita in these high population areas than in rural areas where there are fewer patients, there are sometimes fewer physicians, and people don't often get the best care in those regions. This is another population density map. And this is, many people may recognize this. This is cellular phone map, right? This is like AT&T and Verizon and cellular technology. They have done a great job building their network, right? Over the years, they have really concentrated on making sure that nearly everyone in our country has access to cellular technology. So certainly, hospital systems should be using this technology. In fact, we use this to collaborate real time. We have secure text messaging, and we have teams of people who are constantly interacting and working together, trying to figure out how we're going to approach a case and provide the best care possible. Not every health system is doing that. This is broadband, and the broadband density also kind of follows the population, but you can see it's pretty ubiquitous across the country. So if we could leverage broadband and cellular technology to provide better care and access, then shouldn't we be doing that? And we're starting to do that. Despite this, there are still very large populations that are medically underserved. This is a map from 4 days ago, so this is just updated. Unfortunately, what happens is you can see where there's a high density of people who are underserved, there's also a high mortality in stroke. I'm not sure if you can see that there, but the darkest purple are high mortality in stroke care. There's several in California that are lacking access to good quality care. So it's time for another.
There was a study of the Geriatric Chronic Care Coalition. One of those maps you brought up.
Yeah.
A study came out last week. It said that most of the people who are uninsured in this country are in 110 counties in the entire country. It would be, and most of which are in Los Angeles County specifically. It would be interesting to take the uninsured map and put it on top of those maps.
Right.
And I have a feeling that you would see a big connection.
Absolutely, unfortunately, that's true. Another quick audience response question, and sorry that the system broke down. But greatest challenges in American healthcare. A, lack of goodwill. No, we don't want to do everything. B, lack of resources. Oh, we are one of the best resource countries in the world, right? Maybe the best. C, lack of knowledge. No, that's not it. Sure, I mean, you could make an argument for lack of knowledge.
Could be patient-based.
Some knowledge gaps out there, definitely. But D, poor access to care, poor organization, and fragmented delivery system. Everyone agrees with that. So what are we doing to overcome that? When I travel and I was talking to someone before my talk, my mom comes with us often. She's got a heart rhythm problem, she's got lipid problems, she's got hypertension. And I'm always thinking, what if she has a stroke? Where is she going to go? Where's the stroke center around here? I'm trying to figure out, how is she going to get the best care possible? And there's a lot of people who live out in these beautiful areas of our country, in these rural areas, and they just don't have access to the best hospitals, the academic centers, the tertiary level centers where all the greatest care is being provided. And unfortunately, again, if you look at the maps where the stroke death rates are, a lot of these areas are rural communities and critical access hospitals. In fact, if you layer the critical access hospital map on top of the stroke death rate map, you may also see a tight correlation there. So how do we leverage technology? When we think about the telecom age, it was more of a centralized process. You call in, you get switched over, and you get a connection. And then the internet kind of decentralized everything and allowed people to access from multiple different points and collaborate. And there's this starfish kind of concept where it's a distributed network where it's like a blanket that layers over everything, where people are in real time interacting and trying to figure out how do we best approach a case, how do we best provide care for a patient. And if you take that one step further and you think about kind of a hub and a sub-hub model, which is a lot of how telemedicine networks and telehealth services are being deployed and developed, you have a very high-level tertiary center with lots of teams of people and resources, and they're serving a large population trying to do the best care possible for the patient. And then they're also using all of their knowledge and they're educating sub-hubs who are also serving a large population around them and trying to get patients to have the best access to service and drive better quality. So we are fortunate because we, over the last 5 years, have developed a telemedicine strategy and a telehealth network, and it was through a grant that was received by Dignity Health to provide better stroke care. We had one of our hospitals that had fragmented coverage, not seamless coverage from neurologists. The developers, a family member landed in that hospital, and they recognized the gap. They're smart business people, developers. They know how to build incredible malls and master plan communities, and they said, hey, wait a minute, so if our loved one would have landed in a different hospital, they would have had a neurologist come see them right away, they would have had someone at the bedside to help drive decisions, and in fact, that's true. So they provided a grant, and they said, we want you to improve care throughout our community. Deidre Wentworth, who's here, is our manager of the Neurological Institute. At that time was managing the stroke center, and she recognized the developing theme in medicine, using telemedicine technology to make sure that we can give people access to the best teams of people possible. So we applied that grant to a robotic type of endpoint that allows us to be at someone's bedside in nearly real time. Within a few minutes, we can be at someone's bedside, evaluate them, have a face-to-face evaluation, and provide care. And in fact, we've taken this hospital where we got the grant, and they're now a primary stroke center through our telemedicine network. And the goal from the beginning was to provide timely access, high-quality, specialized healthcare services that are not otherwise readily available. And from the beginning, it's been about access and service. Service, lead with service, deliver on quality. And that creates great value in medicine. There's other added benefits to this. Part of one of my roles is I chair a department of medical specialists for a large medical group here in town. And recruiting and retaining physicians is a very difficult thing, especially in smaller communities with smaller hospitals where there may not be enough population there to really retain and help sustain that practice in that community. So also the call burden chases doctors out of those communities. They don't want to be on call all the time. They want to have a family life, and you can't do it when you're all by yourself. So telemedicine allows those communities to say, look, we're covered 24/7 by this telemedicine network. You come to our community, you'll have this level of hospital responsibility, but you'll be able to build your practice and enjoy your lifestyle here. And that's a huge thing for some of these communities who otherwise wouldn't have access to specialists. If you apply technology appropriately, you can better maintain and manage your resources, you can develop sustainable practice models, and you can definitely manage a population better. Other things that we're starting to recognize in telehealth are cost avoidance. Providing the right care at the right time ends up being the best thing for patients and also saves a lot of money for the healthcare system. If we integrate all of our systems and develop these interdependent relationships, meaning I'm not dependent on you and you're not dependent on me, but if we work together, we get the best outcome possible. That's an added benefit of telehealth. Smart growth. Patients and families are very satisfied with this when they have somebody, a specialist, who comes to the bedside and runs algorithms very quickly and asks them, which they don't know if it's the right questions or not, but they assume it because they can tell your experience and you're knowledgeable and you're trying your best to help make it a very important, critical decision. And then emergency room doctors are very thankful often if they have access to specialists, because emergency room doctors have to know this much and specialists have to know this much. And if you're constantly drilling and practicing and you're experienced, knowledgeable, the cognitive burden of making decisions is a lot less. So for me to beam in and be at a bedside and ask all the right questions and make a good decision, I do it all the time. That's what I'm trained to do. I'm an expert in that. for an emergency room doctor, especially in a critical access hospital, they may be in that situation once every 6 months or once every 3 months. Is it reasonable to expect that they can make all the right decisions and run the algorithms very quickly? So that's, again, a benefit of telemedicine. So we'll talk more specific about stroke now. It's the third, or recently became the fourth leading cause of death in the United States. There's a question later which we'll talk about, where it'll be an interesting question. It's the number one cause of long-term disability, which is incredibly expensive for our healthcare system. Every 45 seconds, somebody's having a stroke. More than 750,000 Americans have a stroke each year. Unfortunately, a good number, 167,000 of them will die. And the cost is very high. And these numbers are probably outdated. It's probably much higher than that there. Recognizing that time is brain, the American Heart, American Stroke Association have developed a national campaign in the last few years trying to make sure that people get into emergency rooms right away, they get assessed to see if they're candidates for effective treatments. Because if you can open blood vessels through either medications or interventions, then you may be able to save a good number of brain cells and synapses here. Every minute, 1.9 million neurons, 14 billion synapses, and 7.5 miles of myelinated fibers. This is a study that came out of UCLA, Jeffrey Sabers, a stroke specialist there. So, knowing what we know about stroke care, there's a definite disparity in how people are treated. About 2 to 8% of patients are treated with IVTPA. Unfortunately, that number should be higher. The highest performing stroke centers, it's around 20%. Within the last couple of years, 64% of hospitals never treated anyone with medication, the FDA-approved medication for stroke. And the harsh reality is that there are not enough specialists to go around. There's only 4 neurologists per 100,000 persons, and they're distributed ineffectively. They're not in all the communities equally. They're more in big cities and less in smaller rural cities. And then a few studies have shown that acute ischemic stroke is often missed or misdiagnosed in a good number of times. Back in 2009 is when the American Stroke, about the time when we were building our network, when the American Stroke Association came out with a recommendation that telestroke networks should be deployed wherever lack of readily available stroke expertise to prevent patients in a given community from accessing a primary stroke center. And then, if there's a reasonable distance and travel time, then the patient may be a candidate for effective therapy.
Is that true even if it's diagnosed by a telehealth stroke team?
Yes. How do you mean?
Can you go back to that slide?
Mm-hmm.
An acute ischemic stroke may be misdiagnosed by a PCP or emergency physician in 7 to 30% of cases when compared with a stroke team. So it doesn't matter whether the stroke team is on site or via telemedicine?
If the stroke team's on site, they would be part of that team making the diagnosis. So it was comparing the best effective model we have, a stroke center with a stroke team readily accessible 24 hours a day, 7 days a week, 365 days a year, to a hospital who doesn't have a stroke service like that. So, yeah. And then we talked about this hub and spoke model. Our goal is to share our knowledge as best possible, bring other hospitals up to primary stroke centers so that patients have access to the best outcomes possible. And we connect all of our hospital centers through technology, using broadband network, using cellular-based technology, whether it's acute care or it's clinic-based care or it's working on the pre-hospital setting, where we know if we can get in and get involved very early, we can make decisions more quickly and hopefully improve outcomes. This is kind of the stratification of a basic stroke center who probably doesn't have neurology coverage, doesn't have the specialist there, but through telestroke we can be there, help drive decisions, and then if patients need to come to our center for expert or more advanced care, then we can move them through our system. Cost effectiveness of acute therapy for stroke has been published on several occasions. This was back in 1998. It was a study done in Canada where their system is a national organized system where every dime that they spend obviously is tracked closely and very important. They were achieving rates less than 2%, And they did an analysis and determined that if they could increase the rates of appropriate care for carefully selected patients with TPA, that they could save billions of dollars for their health system. And it's very important that they point out this is part of an organized, it's not just about giving TPA for stroke. That's not what it's about, really. The people who need it should get it. The people who don't, it's as important decision to make that decision. Those who don't could be harmed or otherwise our candidates should not get the medicine. And that's why getting the right doctors and the right experts to the bedside to make those decisions is very important. But they're pointed out that an organized system of care with stroke units, rehabilitation strategies, improved public awareness, and prevention strategies could save their system billions, $8 billion. If you just look at their thrombolytic rates alone, about 800 million of that over a 20-year time. And this is the best part that I highlighted here. The challenge ahead lies in improving access to thrombolysis, which is a highly rated indicator of the best practice for stroke care by the Canadian Stroke Quality of Care Study Expert Panel. And no matter where you go in the world, people are trying to figure out how to make sure people get access to the best care possible. It's not just Canada, the United States, Europe. They're doing lots of, we'll see, a lot of pre-hospital work to really improve efficiencies and make sure people get access to medicine and get it in a timely manner. This is a cost savings of thrombolytics for like Colorado, 2%, $82,000 a year, at 20%, $828,000 a year. And this is 2005 economic benefit of increasing utilization of IVTPA and ischemic stroke. So in the United States, 616,000 annual ischemic stroke cases could save 73, I think this is in millions. If we increase the rate of thrombolysis to where the highest performing stroke centers deliver care. In California, 8,196,000. So these are some of the highest performing centers throughout the world. These are studies where they've done different process improvements, basically, to try to really even out and make sure that people get access in a timely manner. Sometimes what happens is someone will get to the hospital within a half hour of the window closing, and we haven't been able to deliver therapy effectively. Through a lot of these studies, we've figured out ways to make sure we can really improve the timeline and make sure more people can benefit from medications available. Another audience response question. Appropriately and timely treatment for patients with acute ischemic stroke is A, too costly and not worth the effort. B, works for Canada but not the United States healthcare. C, highly cost effective as part of an organized system of care. Yeah, it's been proven in multiple trials. D, none of the above. It is C. So I wanted to talk about physician workforce issues, because this is one of the biggest things I think that is staring us in the face, and there's a lot of discussion about this. The supply is really outstripping the demand of not only primary care physicians, but also specialty physicians. Projected shortfall of about 49,000 physicians by 2020, and about half of that is primary care, half of that is specialty. The question is, do we really need all of these specialists? There's this debate from the Association of American Medical Colleges that there's even a bigger gap of 124,000 by 2025. However, their health affairs has suggested that because we're going to get more productivity, we're going to use technology a little more effectively, and then we're going to leverage non-physician healthcare workers that these shortages might be overinflated. I'm fearful, and I'm a chair of a department of medical specialists, and I basically recruit and hire physicians as part of my role. I'm fearful that these may be underestimates, actually. So, and let me show you why. So this is the mean self-reported hours worked per week for physicians. So this is the time frame of 1977 through 2007. And you can see there's a significant downtrend here. So we're still getting a lot of productivity out of physicians, more than 50 hours a week, certainly a lot more than a full-time 40-hour-a-week job. But in comparison to what it was maybe 20 or 30 years ago, more than 30 years ago, there's been a significant drop-off here. And those of us who do recruit physicians know that work-life balance is a really important part of all physicians' career. Also, if you look at inflation-adjusted physician fees, looking back to 1999, they've consistently been dropping, which is a big part, I think, of physicians making these career choices and deciding, to do things outside of medicine. Unfortunately, some people are deciding not to go into medicine at all. And then, if you look at self-reported hours worked per week, when you compare resident physicians and non-resident physicians, you see the big, huge drop-off here. And this was when the government regulated the work hours for residents in training. I was the chief resident at UC Davis when they did this, and I had to figure out now how to staff VA clinics and staff continuity specialty clinics, but also keep a very effective call panel and make sure all the emergencies are covered in the emergency room. So it was a very difficult challenge, but we got through it, and they're doing the right thing because sleep-deprived residents aren't making good decisions. But you can see what's also happening in the trend in medicine, that we're having this consistent decline in hours worked. Kind of a hidden return of effective telemedicine network is this idea of being able to recruit and retain physicians in the right places. Some communities who desperately want some neurologists on staff or any type of specialist, the community may not be large enough to sustain that practice. And what happens is physicians get brought into small communities, they get an income guarantee, they get some incentives to make sure that they can cover a percentage of the call. And that's a huge cost to that small rural hospitals. And unfortunately, a lot of times people don't stay in practice for more than a couple of years. They get the income guarantees, they get the call pay, and then they disappear. Through telemedicine, we can make sure that the hospital is effectively covered, make sure they're getting access to the best care possible. And in some of these communities, it's absolutely the right thing to have a neurologist there. But we're working with several hospitals now where the neurologists are very open and upfront about not wanting to be on call all the time. They'll do their share, they'll go to the hospital and see consults, but they can't be on 24/7, 365, 7 days a week. So telemedicine, with our pool of neurologists, there's about 13 of us now, we can provide that hyperacute care, be at the bedside, make a decision, get the patient stabilized, make a determination, do they stay, do they need to come to a higher level of care, and then the next day the doctor in the community picks them up. And that's a huge cost savings to telehealth that I don't think people are realizing yet, and we'll hopefully realize in the near future. Again, this is just more information about the physician shortage problem. There's also malpractice issues that are driving people out of healthcare. This is not for everyone to even read or understand, but this is how complex it is to approach patients with acute stroke symptoms. There's a lot of decisions to be made, and they need to be made now. And our team does this all the time. And again, the cognitive burden of emergency room doctor, especially in a smaller community or rural hospital, this is a very difficult, you can't like bring out a book and try to go through it. It's just not how it works. So this is the importance of having highly trained, highly experienced people get to the bedside in real time. So this is a ischemic stroke, hemorrhagic stroke, how to effectively manage blood pressure and hemorrhagic stroke. All these things are really important. And unfortunately, there's a lot of communities who don't have access to this knowledge base. So quickly, I'm going to run through, and this is not to teach everyone about neuroanatomy and stroke, but just talk about the importance of experienced, well-trained, highly educated people. Stroke is when blood flow stops to the brain. It's interrupted by a blocked vessel or a burst blood vessel, a type of hemorrhagic stroke. And here's examples of that. Clot stops the blood flow and brain cells start to die. Blood vessel ruptures open and causes mass effect and brain cells start to die. There are several subtypes in stroke. There are hemorrhagic strokes, make up about 15-17% of all strokes, and ischemic strokes make up about 83%. And then we classify these into intracerebral hemorrhage, lobar hemorrhage, subarachnoid hemorrhage. And these are devastating stroke syndromes. However, people get the appropriate care at the right time, if the blood pressure is managed, and people can have good outcomes. And we actually have clinical trials that we're involved with where we're looking at blood pressure management, we're looking at microsurgeries that could help really improve people's outcomes. If someone lands in a smaller hospital, doesn't have access to a tertiary level center, then they may not know that's even an option. Ischemic stroke comes in different types: atherothrombotic disease. Cryptogenic type strokes mean we couldn't figure out where the embolus came from, where the clot came from. It's very small vessel strokes like lacunar disease, hypertension, diabetes, hyperlipidemia. Those are the main risk factors for those type of strokes. If you look across the world, it's a huge global burden of stroke. 15 million non-fatal strokes each year, second leading cause of death throughout the world, with 5 million people dying from stroke each year. Major cause of permanent disability. Obviously, there is some age and sex dependency to risks of stroke. Incidence can vary based on geography. Pathophysiology, the brain is an incredible organ, but it only makes up 2% of the entire body mass. And despite its relative small in size, it takes 20% of cardiac output. It's a highly metabolic organ. It needs blood flow, it needs glucose, it needs oxygen, it needs all these components to survive. If you have a drop in the perfusion, or if the brain's not getting enough blood flow, tissue starts to die, and you get functional deficits, and that's how we identify stroke symptoms. You have ischemic brain injury when you have a series of interlocking thresholds that start to cause increasing damage, swelling, and problems. And again, it's all related to a decrement of cerebral blood flow. This is kind of, again, pathophysiology of ischemic stroke. Hemodynamically stable over a certain cerebral blood flow, and then as that starts to drop off, you start to get symptoms, and you can actually get infarcted tissue. And this happens like this, like my neighbor. In an instant, he was having a stroke, and his wife recognized it. A year ago, he had sent her the American Stroke Association face, arm, speech, and time. And she started to do an exam, and they called me very quickly, and my wife called 911, and I got on my phone, and I was texting my team in real time. We were saying, here's the age, here's what's going on, he's coming in right now. And paramedics came, and they were incredible. And they knew how important time is. They knew that the longer time goes, the more brain cells that are lost. In stroke care, we use our knowledge of neuroanatomy to localize where the symptoms may be coming from. An important concept in stroke care is the ischemic penumbra. This used to be theoretical 20 years ago. Now it's a very widely accepted concept where you have brain cells that are dying or dead, and you're not going to recover those, but you have a surrounding penumbra, you have a surrounding hypoperfused area where you can recover those brain cells, and those, if you do, you can significantly reduce disability and improve the outcome. And this is kind of what a penumbra might look like, where there's a core of infarcted tissue that's not going to recover. There's a reversible outer layer where you could, if you reperfuse, if you open that blood vessel, the patient gets the right therapy at the right time, have a better outcome. This is a case of a patient who was visiting through town. They were driving from Oregon down to LA, stopped in Sacramento, and at the hotel, patient started to have trouble manipulating the elevator pad. And her husband recognized that right away. They called an attendant in the lobby, and they called 911. She came to us. She was a candidate for thrombolytic therapy, and sometimes people get the medicine and it doesn't open the blood vessel. They don't get better. And if there's a large enough area that where a blood vessel is closed, we have more advanced interventions where we can open the blood vessel and try to reperfuse brain. So this is a very fancy advanced CT imaging technology. It's called CT perfusion. And we're comparing blood flow, blood volume, and time to peak. And we're looking at whether there's a mismatch here. And indeed there is. There seems to be a significant reduction in the perfusion, and yet the blood flow and the volume seem to be matched. So there's a potential, if we open up this blood vessel, less likely to cause harm and more likely to cause significant benefit. In fact, when our interventional neuroradiologist went and evaluated the vessels and they did the angiogram, initially they saw that there was a missing branch here where the symptoms were coming from. They were able to do some intra-arterial medication and able to open up the blood vessel, and the patient left our hospital in 3 days totally normal. So when we classify ischemic strokes, we break the brain down into territories, anterior, posterior. And part of this, showing you all this, is to kind of emphasize the importance of very experienced, knowledgeable people getting to the bedside to make the right decisions in real time. We kind of went over the different classifications, thrombotic and embolic strokes. The brain vasculature is very complex. Most people, we all memorize this in medical school, and most people forget it because they don't use it all the time. Neurologists do this every single day. This is how we approach our jobs. Everything we do is about localizing and understanding what's going on in the brain. The anterior vessels are coming off the internal carotid, and you can see all the large territory that can be affected if a main branch closes or even if a small peripheral branch closes. In the posterior circulation, these can be the most devastating stroke syndromes because if this large vessel here closes, all the vital centers of your brain live in your brain stem. So you could, die from this stroke syndrome, which is a horrible outcome, but some people, even worse than death, is being locked in, where you can't move any of your extremities. You can understand and you're conscious, but you can't often move all your extremities and sometimes can't even communicate, which is a devastating stroke syndrome outcome. So these are the causes of ischemic stroke: atherothrombosis, embolus, small artery disease, and hypoperfusion. Sometimes we see, unfortunately, people who undergo CPR and they have global hypoperfusion. They just have a massive decrease in their cells, and they all kind of go into this cascade of events. The other thing we are all constantly trying to think of is what caused this stroke and how do we prevent worsening. So a lot of this is about prevention. It's about preventing secondary injuries. How do we not only make a decision right now how to get this person the best outcome possible, but if there is no option, how do we make sure we understand what caused this stroke so that we can prevent another stroke from happening, a worse stroke potentially. And that's what secondary prevention is all about. It's about understanding, localizing, identifying risk factors, and applying the right type of therapies to prevent secondary or recurrent strokes, which we know is a big problem. So a lot of this information is just, again, to emphasize the complexity of the localization. And all these are different symptoms that happen in the carotid territory versus the vertebro-basilar or the posterior circulation. So this is really important risk factors, and identifying patients who have the greatest risk for stroke and providing preventative therapies is in critical importance. We can break it down into modifiable and non-modifiable risk factors. I think that the great thing about University Best Practices and the Right Care Initiative is this is what it's all about. It's educating people to know their numbers, what is their risk, identify their risk, make sure they're on the right medications, and if they land in our ERs and we're having our team evaluate them in a hyperacute situation, that's not ideal. Even though we can do that really well, our system needs to change and be less interventional and more about prevention. So these are the non-modifiable risk factors: age, sex, ethnicity, prior stroke, heredity. And here's a question that's, I didn't know. This is the great thing about preparing talks and learning all the time, and I'm constantly learning. So women are more likely to have a stroke and more likely than men to die from a stroke. True?
True.
False? I just learned this, while preparing for this talk. And then the American Heart Association, the Chronicle Press, just came out with specific guidelines in stroke prevention for women. And they have specific risk factors, including pregnancy, which can cause preeclampsia, birth control pills, hormone-releasing therapy, migraines, and if they smoke when they have a history of migraines, increases their risk, and atrial fibrillation. And I think this is something that the Right Care Initiative should embrace and really get the word out there: is how do we prevent more stroke in our entire population, and how do we make sure that women are educated about their risk of stroke? Because forever, trials and everything years ago were all done mostly in men, and we're now starting to understand what the risk is for our population of women, and we need to really improve on everyone's understanding for this. Well-documented modifiable risk for stroke, hypertension, diabetes, dyslipidemia. I think the University Best Practices, Right Care Initiative is really focusing on that. Other ones, atrial fibrillation, cigarette smoking, especially with migraine, excess alcohol intake, carotid disease, hormonal therapy, and we talked about a lot of those things. And this is really important. Know the signs of stroke. Sudden weakness, numbness of the face, sudden confusion, trouble speaking or understanding, sudden trouble seeing in both eyes, walking, dizziness, loss of balance. And some of these people write off the symptoms and they don't see it as a significant thing. Especially, we get a lot of people in the ER with dizziness or vertigo. This is something that shouldn't be ignored though, because if that's an acute ischemic stroke symptom, that's a posterior circulation problem, and that needs to be addressed immediately. Sudden severe headache, often a sign of subarachnoids or hemorrhages. And then the stroke is emergency, act fast, face, arm, speech, and time. And then our chain of survival and recovery from stroke starts with early recognition, getting EMS involved, just like happened in my house yesterday. Getting patients delivered to the stroke center, evaluating them immediately, making sure they're getting access to the right therapies and potential interventions. CT scan is our priority in hyperacute stroke care. It can help us distinguish between bleeding and no bleeding. About 95% accurate for picking up subarachnoid. Sometimes people unfortunately have large brain masses that's presenting with stroke symptoms. This is a quick case study, a patient who I evaluated through our telemedicine network. This is a couple years ago now. 47 years old, dizziness. That's a tough symptom, especially for ER doctors. They're not used to thinking about how the brain is organized and how the anatomy is. Dizziness, slight headache, left-sided weakness, onset at 8:30 p.m., but he was last normal at 6:30 p.m., so that changed our time window a little bit. He was having chronic neck and back pain, and that sometimes adds to the confusion. He's on a couple pain medication, and he's actually getting some Adderall off the street. So the call came in, and it came through Deidre, actually, I think, took this call, and the story was kind of like, we're not sure, can you help us evaluate this patient? So I got in on the robot, and as soon as I saw the patient, I recognized very quickly that he had cross symptoms, and I was very concerned about a potential posterior circulation event. And in fact, when I did his neurological examination, he had an eye movement abnormality, and I localized the brainstem syndrome. I scored him on the NIDS and NIH stroke scale. His CT scan was fine without evidence of bleeding. So we offered him thrombolytic therapy, which he accepted, and we always explained that there is about 30 out of 100 people who will improve with this medicine. Some will be normal to near normal, some will have a significant improvement in their disability. Many people won't improve at all, and there are a few people who may develop bleeding. They may develop a symptomatic hemorrhage and could have a worse outcome. So we're pretty careful about who we select for the medicine, and we're pretty good about how we explain the risk involved. So we gave him thrombolytic therapy, and the problem is, in this type of syndrome where there's potential blockage in the back of the brain, the medicine might not work. And if it doesn't work, we still have to do something, because if he goes on to complete this stroke, he may be locked in or he might die. So we brought him to our tertiary level center. We performed angiography on him. We saw that there were potentially a big clots in his basilar artery. Our interventional neuroradiologist did angiogram, which showed a very stenotic blood vessel, and unfortunately had some aberrant anatomy. So there's supposed to be two blood vessels feeding this big basilar. One side is actually going into another blood vessel, so it's not. So he's living off of one vertebral artery that's going into his basilar, and that was very narrowed, and there was thrombus kind of propagating up into his basilar. So our interventional neuroradiologist went in and placed a balloon angioplasty there, opened up the vessel, and the patient went from this type of pre-procedural anatomy where he's not getting any blood flow to his brain stem or the back part of his brain to this post-procedure, which is near normal anatomy, as normal as it can be in him anyways. So he got that intervention, and later, about a week later, came back and had a stent placed because he had such stenotic changes there. He was a smoker, which probably contributed to this. His cholesterol was elevated. So it unfortunately happens, people come and they don't really have risk factors, to our knowledge, and then all of a sudden, they got all these medications or leaving the hospital. So basilar artery occlusions, severe syndrome, high mortality, and severe disability if it's not caught and treated effectively. Again, the stroke chain of survival. And then the American Stroke Association, American Heart Association based on evidence from timeframes, and multiple studies have been done, looking at the odds ratios, the number needed to treat for medication. The sooner the medication can be delivered, the better off patients will be. National campaign looking at target stroke, because we know if we can improve process, we can improve outcomes. We're currently trying to work with our pre-hospital colleagues. We know from trials that have been done throughout the world that if you can get, in this case, a neurologist inside the ambulance, which is probably not going to happen in the United States, however, we might be able to get them remotely there. A CT scanner in the ambulance, which again is not very cost effective, but it does save a lot of time. And then probably the best model is called the Helsinki model, where there's pre-notification, everybody's prepared when the ambulance arrives, the patient goes right from the triage in the emergency room to the CT scanner. So they don't waste time unloading the patient from the emergency or the EMS gurney to the emergency room gurney, and that whole process probably wastes about 10 or 15 minutes time. So they go right from the EMS stretcher to the CT scanner, and then in their case they deliver therapy right in the CT scanner. So what is Dignity Health doing? How are we looking at that evidence and trying to improve our processes? We're working with EMS and our emergency room colleagues, and we implemented this exact model where EMS comes in, ER doctors there, door to doc time is 0 minutes. Meet them at the door basically. We have a critical response nurse and what's called the MICN, the nurse in the ER that's in charge of triaging. And the team meets the patient, and the EMS pushes them right to CT for us. They take them right from the ambulance bay into CT. We get a CT scan right away. And what we've been able to do, I think everyone can see this, is since we've implemented that process, we've been significantly improved our door-to-needle times and shaved about 20 minutes off of our door-to-needle time. Which is pretty phenomenal. We're around the target of 60 minutes, and now we're pretty consistently down around 30 minutes. And we're constantly trying to figure out how we can improve this. Yeah, and we're going to adopt this at all of our hospitals. This was at Mercy San Juan Medical Center, but we're currently implementing this same strategy. And EMS they want to do the right thing. It's much like coronary care, where there was a time when they stopped and they analyzed and they try to figure things out. Now they got EKG, they get the enzymes, and then they go right off to the cath lab. So similar type of approach. Part of our network, and I know I'm a little bit over time here, but this is really important. The transfer center is like a core of our network. People can call our transfer center, we'll give them advice, and we'll get on robots right away, we'll take care of them. It's all about workflow. Our director and our manager help really push out this information. And then it's about feedback too. It's a continuous process of quality improvement. So we provide our timelines, and we ask our partner sites to provide us with their information so we can help them meet their targets and improve their timelines. This is a sample of how we give them feedback and information. Here's your targets, here's how you performed in those targets. And this is incredibly valuable information. We've also had to work a great deal on our responsiveness, and this is where the responsiveness part of the talk is. When we started this a few years ago, we weren't getting on the robot right away, we weren't returning our pages in a timely manner. We really focused on this, and we treat all of our partner sites just like we treat our physical response emergency room. And we're on that robot sometimes quicker because we're not up on the ward. It may take us more than 5 minutes to walk down. We're on the robot in their ER within 5 minutes pretty consistently. And that's a huge advantage for emergency room doctors who are desperate just for any type of advice or feedback. This is a more sophisticated timeline that we developed. We made it a little more simple than this because this was a little hard to follow. This is, again, we're tracking everything. Whether they get medicine or not, whether they go to intervention or not, we're looking at all those details. And this is a more straightforward way where we can display to our partner sites exactly what the targets are and help give them feedback. But our biggest challenge with our partner sites is getting triggered. Sometimes we wait 30 minutes, 45 minutes, and we're not really sure why, so we continuously give them feedback to make sure they trigger us more often. We're also developing case studies and giving them feedback through this type of straightforward case study approach. Our network started in one hospital, and then it continues to expand. Now we're expanded across most of California, moving out to the Central Coast as well. The majority of these hospitals are Dignity Health hospitals. There are a few of them that are not. They're critical access hospitals, non-Dignity Health, or we work with also the North Bay healthcare system. help build up their neuroscience program. They're developing a stroke center right now. You'll notice that we're in areas where those patients could never reasonably expected to come to us for the higher, more advanced levels of care. So what we've done is we've worked in collaboration with comprehensive stroke centers like Stanford University and UCLA, where we can make the critical decisions right now, and then we can help that hospital partner site, whether it's out on the Central Coast or it's in Oxnard, wherever they are, we can help them make the decision of transferring that patient to the higher level of care, which is a difficult thing sometimes. And we've opened up the pathway. We have direct connections to the stroke team at Stanford and also the neuro ICU at UCLA. Why is this so important to hospitals? Because CMS says so, CMS pays the bills, and they are now making this part of the all or none core bundles for the hospitals. So whether you're an advocate of effective hyperacute therapy for stroke or not, or the CMS is tracking this very closely, and every patient who lands in an emergency room within the time window needs to be evaluated in a timely manner, needs to be offered therapy. If the therapies decline, that's part of why we get to the bedside and help families and patients make the decisions that they have to make. Our hospital, Dignity Health System, has made this a corporate, more than 40 hospitals across their company. Everyone has this all or none bundle as their target, and our telemedicine network is very actively helping that. Let's get that slide. So this is another case I want to just highlight this, and maybe I'll try to end with this case, but this is not a feel-good case, but this is part of what the return in telemedicine is. So this is a 63-year-old woman who had sudden collapse. When the emergency medical technicians and paramedics got to her, she was pulseless. They had to perform CPR for nearly 20 minutes, and then she had returned to spontaneous circulation. She was intubated in the field. She came into the emergency room in Stockton. She was very hypertensive, blood pressure in 250s over 120s, and during her hospitalization, she went to a CT scanner, was found to have a massive hemorrhage. She suddenly became profoundly hypotensive. She required multiple pressors just to maintain her systolic in the hundreds. She didn't have a lot of medical history, just diabetes, hypertension. She didn't smoke or drink alcohol. So the ER doctor called us up and said, this is really bad hemorrhage. This is horrible. All these things are going on. So this patient, basically based on the history here, is not going to recover from this. Okay, this is a severe acute brain injury. This is a subarachnoid hemorrhage, and this was confounded by severe hypoperfusion. So during her CPR, she was having global damage to her cells. So you have increased ICP because of the subarachnoid. You have reduced cerebral blood flow or cardiac output because of the pulse, the pulseless electrical activity, which is unfortunately what happens sometimes in subarachnoid hemorrhage. They have a cardiac dysrhythmia and high mortality in these type of brain hemorrhages. And this is a more normal kind of comparison. So basically, her exam was nonverbal, intubated, no spontaneous eye opening, no motor activity. Pupils were large, non-reactive, no corneal, no dowels, no cough gag. So these are all the things that we're looking at to assess brain function. She does not withdraw noxious stimuli. Essentially, these are very difficult cases for ER doctors because they're not really well versed in doing brain death exams and trying to explain to families why there's nothing that can be done. So I got involved and evaluated the patient through our telemedicine. I counseled the family. The patient was appropriately cared for at her local hospital and ended up kind of being a comfort care case because there was no available, there was nothing that we could have done in this scenario, and I think that's a big value of telemedicine as well. There's a lot of more slides here. We look very closely at our volumes. We look at what time of the days we're being activated, what days of the week, and it's pretty even across the board as far as days of the week we're being activated. Again, strokes can happen anywhere, anytime. It's interesting, we have this peak between about 9 and noon, and then a second peak between around dinner time, 1800 and 2100 hours. And then at night, it kind of levels off as people are sleeping. We take a
Why
lot
do
of,
you think the Thursday, Friday, is that because people are depriving themselves of sleep?
I don't know, MIs are more common on Monday mornings, right, or something like that? No, I know, I don't know if we understand all of this yet. but we
In
have the
one of our
information.
summits 2 years ago, there was a slide that showed that if people get less than X hours, their risk of stroke goes way up, and it seems like that's something the public doesn't really understand.
Part of my training is sleep medicine. I'm board certified in sleep medicine, so obviously it's near and dear to my heart, making sure people get the appropriate amount of sleep, making sure that they get access to appropriate therapies for that. But yeah, as we analyze this more, there's a number of manuscripts that are in process right now, especially related to our process improvement in the ERs, and how we're kind of leveraging a core group of experts across an entire hospital system and throughout critical access areas. Can I have like 5 more minutes? Okay, so this is a really, so as we're really good at hyperacute situations. And that's something that we've been doing for a long time. But how do we interact with people in their homes? People that have chronic diseases, people who may be failing to take their medicines, not because they don't want to take their medicines, but because they're forgetting or they're confused or whatever. How do we leverage technology to get into people's homes and make sure they're getting the right care and make sure they're taking their medicines? So we're using telemedicine. This is called a Care Innovation tablet. And Jim Roxburgh coined this the virtually integrated patient care module. So in this scenario, the patient is interacting with the nurse who's counseling about blood pressure and medications and making sure that they're getting all the right medicines, tracking their weight, that type of thing. And we're currently doing a trial where we're looking at deploying this type of technology, which is kind of been done before, but we're specifically targeting stroke risk patients who've been in the ER, could have been for anything, but they have AFib, they have hypertension, they have diabetes, they have hyperlipidemia. So we're specifically targeting this population with the endpoint of reducing ER admissions and reducing strokes as an endpoint. So we're hoping that we've enrolled, we're trying to do 30 control and 30 with the device, and hopefully that will be available within the next year or so.
So in other words, the trial hasn't started and you're looking for patients?
The trial has started, but we are still looking for patients. Yeah. So risk factors for stroke, again, lifestyle modification, risk factor modification, and this is the number of preventable strokes based on the 700,000 a year or so. If we can effectively control hypertension, hopefully we could prevent more than half of those strokes. And this is a big problem. We see a lot of hemorrhagic strokes, people that lost their insurance, went off their blood pressure medicine for a couple of months, and now they're in our emergency room with a big hemorrhage in part of their brain. Same thing with cholesterol medicines. If we could get everyone to know their numbers, be on medication for their cholesterol, then we could significantly reduce stroke risk. Smoking is an obvious one. I'm glad to see that CVS and other companies are now moving away from selling cigarettes, decrease access to cigarettes and increase access to medical care is what we need, right? Atrial fibrillation is a big problem. People are not on the right medications, and even when they are, sometimes they're missing doses. People need continuous counseling about heavy alcohol use. And then I talked briefly about primary prevention, which is making sure people know their numbers and get on the right therapies. And then secondary prevention is once somebody's had an event, analyzing every detail of what could have caused that and making sure they get on the appropriate therapies. And then there's a stroke risk scorecard, which is published by the National Stroke Association. I did my score last night, and I'm in the low risk category, fortunately. But some people don't even know; they don't have any idea what their risk is. And I think we need to get this information out there so people know their risk. This is part of our population management strategy, using telemedicine links, we're doing a diabetes study right now, using text messaging to try to make sure people are taking their medicines and tracking their blood sugars. And these are some of the goals and metrics that we're following for our Care Innovations trial that we're doing. Now I said something in my, this is the triple aim, I said something in my talk about triple aim and quadruple aim, and people were like, what is that? So triple aim, I think, is a great focus. improving the population health, decreasing costs, improving patient satisfaction. But there's this movement now in the military health services looking at the quadruple aim, where they're enabling a medically ready force and making sure that there's resiliency built in. I think part of this readiness is using telemedicine, using technology basically. Improving quality, making sure that everything we do is centered around our patients and their families, and then obviously, I always contend that if we do the right thing for our patients, we're going to see that bending in the cost curve. And then this is, everyone knows Don Berwick, every system is perfectly designed to get the results it gets. Unfortunately, and I think that's why we are here, to try to figure out how we can better collaborate and improve our systems of care, meet these 6 aims of improving safety, patient-centeredness, efficacy, effectiveness, timeliness, equity. Again, I think telemedicine and technology helps us achieve all these things. And then, as I said in the beginning, the Royal Society of Medicine meeting in London really influenced my thinking a great deal about this. Being involved for more than 5 years using telemedicine and technology to improve care. It always helps when you see someone even more experienced than you who just provides such a great, eloquent talk. So Adam Darkins, he's from the UK, and he was kind of back there as a homecoming. He provided this kind of keynote speech where he basically didn't have any PowerPoint slides or anything, just delivered this great discussion. And he's now being retained by National Health Services to kind of improve their systems of care, because surprisingly, despite them being a nationalized health system, they still don't got this down. They don't know exactly how to break down the silos and get everything working together. But these are some of Adam Darkin's thought about telehealth, and I really appreciated his thoughts about this, because it's not about the box or the cloud, right? It's all about the service, and it's all about solving problems and making sure people have access to care. It's about creating large networks where we can have enhanced access, improving service, improving quality, distributing knowledge. And then he said this, and this is where I started thinking about this. The healthcare system, especially ours, it rewards the intervention, but not necessarily making the right decision at the right time. So there are people who are best suited to make the right decision at the right time, every time. And how do we get all those things connected together? So I'll end there, and this is our team that's heavily involved in everything that we do. Thank you.
Minutes, if there are any questions from the audience, because there was a lot of information, and thank you, Dr. Shatzel.
Sorry.
But I know there could be a lot of questions, so if we could just limit it to just a couple. Anybody have? There's a question.
I have a question. So I'm just relocated to San Francisco actually 6 months ago from New Mexico, and so I've been involved with telemedicine there. The ECHO project, of course, and then also through some school-based health centers, we actually have some telehealth equipment where we can remotely provide care. So when you're talking about robots, tell me exactly what you're talking about. Is it a laptop and a computer on one end, and someone trained on the other end? I mean, I probably missed this or something.
So yeah, I tried to de-emphasize the robot part of it, but so we have robotic endpoints, and the robotic part is we can move the head, we can zoom in, zoom out,
right,
and get a better advantage of examining the patient. Some of our robots drive themselves, some of them we have to drive, and some of them are on push carts.
Okay.
So, but it allows us to be remotely present at the bedside,
Right.
in real time,
Right.
to interact with the patient and their family, the emergency room doctors, to again drive the right decision, basically.
Right, so that unit is physically located at the remote site, and you could technically do that from your home, or no?
Yeah, so
Okay.
I have my laptops here. So I have a laptop workstation. There's actually an iPad app, so if I'm out and about, I can grab my iPad and I can link into the system, and it's all, HIPAA secure and compliant and all that type of thing. So I can do that from anywhere, and they're now working on an iPhone app. So you can literally log into your iPhone and be examining somebody. There's not enough space there to do your charting and documentation, but we can do all that through our laptop workstation. And then the other thing that I talked about was this product that we're using called EmergeMD, which is HIPAA secure text messaging. When you're trying to coordinate across 4 and 5 specialties, which is often what we're doing when we've got hemorrhages, subarachnoids, neurocritical care, all these things, we have to have ways of getting together in real time. If I have to call the operator every time I need to go hold somebody, we just can't get it done. So it's, the more we're getting things pushed out and, kind of that distributed model, the better, the
Absolutely.
more effective we're becoming.
Well, and that's the beauty of it. You can do it from your home. You can do it from wherever you are as a specialist.
Yep.
And the robot is there, so that's great.
Correct.
Dr. Kemp Buss here.
Is the robot in the rural hospitals or the remote hospitals only used for strokes, or is that used for other specialists to kind of remote in?
So yeah, we're expanding into intensive care coverage. We're expanding into mental health, which is a huge disparity, right? Much bigger than stroke by numbers. And we have a number of services. They use this for pediatric intensive care, neonatal intensive care. So we're leveraging the robotic endpoints and the technology for all these different services. So and then there's nephrology. There's a lot of use cases that are coming online. Hyperacute stroke, again, that was our grant early on, and that was our core. But it's really spilling over into all these different areas. So.
Can we have one more question? I think it was back in the back.
Are the obstacles to broader adoption of this organizational or technical? And if organizational, are they financial or attitudinal?
I think. So I think they're more organizational and somewhat attitudinal. The technology's there, the technology's available. Some people get stuck on the cost of the technology, but if they actually thought about where all the returns are coming from all these different better care, better responsiveness, they realize that they're coming out ahead in the long run. But that's part of the silos in medicine. Whose return is it anyways, right? Is it the health plan's return, the hospital's return, the doctor's return? Whose return is it? And that's part of our challenge ahead of us.
Great.
I'm going to
Good,
take
thank
the prerogative and ask one more question. Sorry, Dr. Revelo. You had expressed that you had a vision for the capital region of how the systems could work together, but I didn't hear you talk about that. Could you just say a couple minutes about your vision?
Yeah, we actually do work together. UC Davis is the premier place for pediatric intensive care and how to approach very sick kids, and Dr. Marson works with us at some of our Dignity Health hospitals. I think that there is a great opportunity in stroke care, mental health, and a lot of these other services where we could be working together in more of a collaborative way. But there is some inroads to trying to get closer together. We're meeting with UC Davis in a week or two. And then, the pre-hospital setting, which, no systems control that. That's directed by the county. That's a huge opportunity to make sure that people are at least getting transport to the best places for the best care possible. So,
Thank you.
sure.
Great. Well, thank you. Really appreciate that. And that's given us a lot of food for thought, a lot of information. And so, of course, one of the things that we at RightCare really work toward is the idea of bringing these particular issues and having you have conversations both here and then, more importantly, to take this information and have conversations back home to kind of identify ways to improve the care that we're delivering. And so